certain ways from medicine to Sujin.
Good morning, everyone. I like to present on behalf of Medicine 2 and certain ways. Presenting Mrs. X, 23-year-old nursing student from CMC, present with a complaint of fever for 5 days, high-grade fever associated with chills and rigor, sore throat for 5 days, dry cough for 5 days. She had developed initially a rash on the chest on day 3 of the fever, which had eventually settled within. So we don't have a picture of what was the rash or anything during that. Past history wise, she had a typhoid fever in 2020 for treated with cephalosporins, got relief, and she was vaccinated for typhoid and COVID-19. There was no family history of the same. General examination wise, so on day 2 of her admission, when she had come, she had developed a erythematous rash behind her ears, spreading centripetally or spreading centripetally. The oral cavity did not show any lesions. There was no Ishka. When she had initially presented, she was tachycardic, otherwise vitally stable. General examination wise, no pallor, cyanosis, lymphadenopathy, edema. Systemic examination was unremarkable. So this is a 23-year-old female with a fever and rash for a period of 5 days. So the differentials we had initially considered were measles, dengue, scrub, COVID-19, and malaria. So on the routine evaluation, we had found general exam evaluation for hemoglobin of 10.8, the WBC of 5,900, platelets of 220, LFT was within normal limits, differential counts, neutrophils of 72, lymphocytes of 7, monocytes of 1. Urine analysis showed WBC, however, she did not have any pain during mixation or anything. Creatinine was 0. ECG and X-ray was normal. So we initially done the serology for that. Dengue serology was negative, scrub was negative, malaria was negative, COVID-19 was negative, and wheel Felix also was negative. We had done a anti-measles antibody, IgM, which was also negative in this patients. However, we are also taken a throat swab for this patient, which had come to be positive for measles virus. So today I like to focus on the discrepancy between measles IgM and PCR testings for measles. So measles by case definition by World Health Organization is fever with any maculopapular rash along with cough or coryza or conjunctivitis, or any person in health worker or a clinician who who had direct contact with measles, the suspicion of measles should be made. So the diagnostic test would be usually measles IgM antibody or measles detection by PCR through throat swab, urine, nasopharyngeal swab, or a direct epidemiological image to a confirmed case by either one of the methods. So this is the CDC guidelines. CDC guidelines for measles testing. So in case of PCR, PCR can be collected ideally within, in case of IgM, if it's collected within 3 days of onset of rash, could be negative, and IgM can only be positive only after, is high likely chance of IgM to be positive only after 3 days of rash. So IgM doesn't alone exclude that measles is not present. So the simultaneous RT-PCR also should be done in all patients who are suspected to have measles, because it can detect measles at a very early onset, and detecting measles at a very early onset is very important, because since it's being a highly contagious disease, detecting it early is very important in these patients. Our IgG antibody is can only help in patients for detecting immunity. So this so this is a diagram which had shown the distribution of symptoms and the positivity sample collection days for RT-PCR and IgM ELISA. This is also a diagram which is also taken from Lancet, which got show the infectious disease of measles. So basically, measles is infectious between 4 days before the onset of fever and 4 days after, 4 days before the onset of rash and 4 days after the onset of rash. Oral samples have high urine samples and throat swab PCR could be negative after 10th day of rash, and oral fluids can be positive still later on. IgM can be positive only after the IgM is usually more like chances of IgM being positive are more after the third day rather than the third day, and IgG cannot be used for measles identification. So this is a World Health Organization algorithm for measles detection in a patient. So if you have an adequate sample, if measles IgM being positive in the patient and recent measles vaccination, the patient is highly likely to have an IgM antibody positive. It's less likely that it's very difficult to confirm with that. And if there's no adequate specimen, epidemiologically link can be used. So this is also taken from Lancet, in which it emphasizes the essential of using PCR diagnostic materials in diagnosis of measles, as it has early chance of detecting measles. However, it's not feasible at the disadvantage being it's not feasible at every center. IgM ELISA could be negative in less than 3 days of infection, and in case of previous vaccinations, IgM ELISA could be negative. This is also a diagnostic taken from Lancet, in which RT-PCR could be positive in case of acute infection, and IgM ELISA could be positive in case of past infection and in case of acute infection. Or IgM ELISA also could mean that there is a recent infection. RT-PCR being a fast method, however, it's very costly. It's not a cheap and easy method. It requires quite expertise and manpower. However, IgM ELISA does not require the same, and the chance of IgM ELISA being false positive is also quite high. So I like to focus on a large study which is done in 2018 in China, for emphasizing the importance of RT-PCR in supplementary laboratory diagnosis measles in elimination program in China. Basically, they had included almost 50,000 cases of suspected probable measles, with a probable measles being person with a hospital person with a fever, with a rash, with a cough, coryza, or conjunctivitis, with a and also with 395 people. Also, they had included with probable suspected without rash. So they have collected these samples and part of the measles surveillance program, and they test simultaneously for IgM and RT-PCR in these patients. So it had shown that the results were showing that the proportion of IgM negative and viral RT-PCR being positive in 0 to 3 days was up to 14.4% for measles with rash, and almost about 50% of the patients can be diagnosed by RT-PCR when the measles presents with when the measles is on its early stage presenting without a rash. And the proportion of IgM negative and RT-PCR being positive increased with the increase in the measles vaccination dose. So it's important that in case of it's important to focus on the fact that it helps in diagnosing RT-PCR helps in diagnosing measles at a very early point in time, even when the IgM is negative, and it can be also used in patients with secondary vaccine failure for previously received vaccine. However, in these patients, even though IgM antibody won't be positive even after 3 days. So the learning points will be the case definition, the diagnostic methods of measles, the emphasizing the appropriate timing for testing for measles.
Thank you. Questions and comments? Did you repeat an IgM for this patient later?
No, we haven't repeated it.
Probably it is worthwhile. No? See, this 14% IgM negativity, you're talking about somebody within the first 3 days, right? 14%. So the patient presented with 5 days of illness.
Our patient with 5 days of fever with so we had taken the sample. Even so, she had described a rash in the chest, but it had resolved over within 1 day.
So when you saw there was no rash?
When you saw there was no rash. The rash had developed only on day 2. We had sent the sample before.
So all the more reason patient presented with 5 days of illness. So the duration of illness is at least 5 days. Usually by 3 to 5 days, vast majority of them are positive, and you're not finding a rash unless you argue that this is we had done the PCR. What they had done was RT-PCR in our lab. So that is usually much more specific. It will be worthwhile looking at, repeating the IgM and seeing whether there's a bit unusual beyond 5 days, the IgM not being positive. Because that's how usually you would diagnose, no? The convalescence era, there will be doubling of, the IgM titer. You saw the curve, no? 3 to 5 days, it will start rising very well. And by more than a week or so, it will be definitely will be detectable. Any other questions or comments? Comments or questions from people online? If none, thank you, Rohit. We will, before we close today's meeting, we are supposed to choose the best case presenter, which is Namrata Matthew, Globetrotting. This is the case of IBD with latent CMV infection, which is probably reactivated. Congratulations, Namrata. Thank you, and we'll close today's meeting. Thanks for joining.